Okay, great. So thank you for the opportunity here. I'm just presenting on lipid-weighted intraoperative photoacoustic tomography of breast tumors and volumetric comparison to preoperative MRI. I'd like to acknowledge my supervisor for this work. That was Dr. Carson, as well as our clinical collaborators, Drs. Muriel Brackstone and Anna Kornecki, and our research coordinator, Dr. Chamson Reg, and the following sources of funding. Breast cancer continues to be a common problem for women. It is, in fact, now the most common cancer to be diagnosed, superseding lung cancer for the first time, excluding skin cancer, of course. Worldwide, about 2.3 million women are diagnosed annually, and leading to about 685,000 deaths. So about 1 in 8 women are expected to be diagnosed over their lifetime. And this is a serious problem for women, especially those over the age of 50 or over 40, given certain risk factors. To combat this problem, regular screening programs have been implemented in developed countries. For example, at our center, women who present with suspicious imaging results are usually passed on to receive a biopsy procedure. And ultimately, tissue samples from the biopsy are tested for cancer cells. And if the diagnosis comes positive, then cancer staging is performed in order to evaluate the best treatment option. In cases of early cancer, typically breast-conserving surgery is recommended. In cases of more advanced cancer, possibly neoadjuvant therapy can be used to reduce the size of the tumor and possibly offer an effective surgical option. Ultimately, the specimen the excised specimen is sent to pathology, where a detailed analysis is performed to evaluate the surgical margins and ensure a complete resection of the tumor lesion. This process is associated with negative side effects, uncertainty, discomfort, and potentially a financial burden caused by leave from employment. The most common imaging modalities used currently to evaluate breast tumor lesions and for screening purposes are mammography, ultrasound, and dynamic contrast enhanced MRI. While all of these modalities have their strengths and weaknesses, it's quite known that mammography and ultrasound, while they're very popular because they're fast and inexpensive, they do offer poor performance in dense breasts and only offer typically 2-dimensional views. On the other hand, magnetic resonance imaging does offer 3-dimensional views and is independent of breast density, but it is a complicated procedure. It tends to be expensive and tends to have a low specificity, which leads to high false positives. And this brings me to the objective of our work. And this was to evaluate a new imaging modality called Intraoperative Photoacoustic Screening, or iPAS, for the potential of effectiveness in evaluating breast cancer lesions intraoperatively. So the following video demonstrates our intraoperative imaging protocol. Typically, a surgeon presents a freshly excised lumpectomy specimen. The specimen is placed inside a saline-filled Ziploc bag, which is carefully sealed, and so bubbles are allowed to escape. This is mounted on a customized lumpectomy specimen holder, which is then inserted into the scanner, and then the scan begins. The system is capable of multispectral illumination ranging from 680 to 950 nanometers for excitation. Removal of the front panel gives you a better view of the inner workings of this imaging instrument. At this point, without going into too much technical details, I'd just like to point out that at the heart of the system is a semicircular 24-channel transducer array that was custom designed by our group. Seen here and in the video, rotating around the tissue sample, which was placed in the center of the array. A general idea of how this process can be used to generate images is as follows. A short laser pulse is fired into the tissue sample, which the light is then diffusely absorbed, causing a slight but rapid temperature increase. This causes the emission of a ultrasonic wave that travels away from its source and can be detected by the surrounding transducers. By repeating this procedure over the entire imaging volume and in conjunction with any number of image reconstruction algorithms, a three-dimensional image of the absorber distribution can be generated. And the important thing to point out about the image is that the contrast is actually optical contrast, even though it was delivered through an ultrasound wave. That means that you can get optical information at a high resolution from deep tissue, even with scattering tissues such as living tissues. And so why is this optical contrast really useful for us? So an examination of the near-infrared optical absorption spectrum of dominant chromophores found in breast tissue reveals that there are some unique spectral features that you can take advantage of. For example, at 690 nanometers, deoxyhemoglobin is the dominant absorber. On the other hand, at 930 nanometers, lipids or fat is the dominant absorber. So by narrow band illumination of the tissue sample, you can excite particular chromophores, and assuming that the tumor mass has different optical properties from the surrounding tissues, you can then reconstruct a contrasting image visualizing the actual tumor lesion. So I'm going to just demonstrate this using some of our clinical examples, just to provide some visual demonstration. So in this case, a 60-year-old patient was diagnosed with a left-sided breast cancer, BIRAT6, and they underwent a biopsy, ultrasound-guided biopsy, which came back as positive for cancer, and they ended up undergoing breast-conserving surgery. During the surgery, we used our system intraoperatively to image the lesion, and the results are shown here. On the top left is the iPAS or our system's image at 930 nanometers, so it is a lipid-weighted image. And also I should note the pathologist, after sending the sample back, pathologist reported that this specimen contained a multifocal tumor with two masses approximately 15 and 17 millimeters in diameter, along with the grade 3 DCIS or in situ disease. So this was a combination of multifocal tumors as well as in situ tumor. And this was found concordant with our iPAS imaging results intraoperatively, as it shows a spiculated lesion with roughly two areas of focal tumors, also with intermediate segmental structures indicative of DCIS. This is partially corroborated also with our X-ray image here, however, and also ultrasound. There is some suspicious results there, but the findings are not as clear, and it is not as easy to evaluate the lesion itself as a result. So moving on to another case, in this case, this was an invasive tumor combined with an in situ carcinoma. And in this case, the patient was diagnosed also with a stereotactic biopsy. And what can be appreciated here in this image, as you go through the top stack of images provided by the lipid-weighted photoacoustic system, is the fact that as you trace the centrally located at first, starting in slide 6 millimeter depth, as you trace the tumor mass, the hypointense tumor mass, towards depth at around 11 millimeters, you note that it breaks through to the margin. After pathological examination, it was revealed that, in fact, this was a positive margin, and the patient was sent back for a second surgery. Contrary to this, when you examine the ultrasound results, for example, even at slide 11, it is not entirely clear that this margin has been invaded. And as a result, this information would not have been, it was not available at the time of surgery to intervene. And this is better appreciated in the larger slides on the bottom, where the white arrow indicates the area of involvement on the photoacoustics iPAS scan. And there's also a photograph there for reference, which shows the surgical orientation sutures. They're also pointed out using small green arrows. And these sutures are placed there by the surgeon to allow us to orient the specimen so that we can correlate our findings with pathology and be able to identify the involved margins. So if this information, for instance, was able to be shared with the surgeon at the time of surgery, this patient may have been spared a second procedure. Okay, moving on to another case that demonstrates the volumetric assessment of these lesions. So here you have a patient, a 53-year-old patient that was diagnosed with a grade 1 lesion in the right breast, in the outer upper right breast. And this can be appreciated in the perspective view of the dynamic contrast enhanced MRI in the top left of panel A. And on the right of panel A are selected slices indicated also in the perspective view with color depth encoding. And these slices show a gradient echo T1 weighted MRI image at the top without fat subtraction. And below that, a dynamic contrast enhanced series, which clearly show the tumor mass from margin to margin. This tumor mass is not as easily appreciated in the gradient echo MRI, where it is noticed that the inferior margin is involved with a dense fibroglandular tissue, making it difficult to delineate without the contrast enhancement. And in the middle of the slide, you can also see the concept of how we calculated the MRI and the iPAS volumes using slice thickness and segmentation. The bottom stack, the bottom panel B, shows the similar procedure. However, this is done for the intraoperatively excised specimen, where we do virtual slicing, and then we show the slices also depth encoded on the right, with the photoacoustic iPAS slices on the top stack and the ultrasound on the bottom. So here you can appreciate the tumor mass in the photoacoustic slides reasonably well agreeing with the MRI results from dynamic contrast enhanced results. And also the ultrasound shows the tumor mass as well, but as is often the case, especially in dense breasts, the tumor mass was quite significantly underestimated in this case. So this case also serves to indicate, show and highlight the truly useful clinical potential of the system in its ability to have that breast density independent result. And these are selected slides of all available imaging modalities for this particular specimen, including the photoacoustic iPAS scan of lipid-weighted contrast, the X-ray, as well as ultrasound, dynamic contrast enhanced MRI, and gradient echo MRI. The dynamic contrast enhanced MRI and gradient echo MRI were preoperative scans. The top panels show all intraoperative scans. There is a fairly good agreement here between the dynamic contrast enhanced and iPAS as well. And again, it highlights the difficulty in examining these dense breast lesions on even X-ray or ultrasound, and trying to get a good agreement with established state-of-the-art standards. So I'm going to move on now to statistical summary of our data. We had 12 patients in this trial here, consecutive patients with a median age of 50 years old and a range of 33 to 75 years. 6 of the patients had grade 1 tumors. 2 of them had grade 2, and 2 had grade 3. There was actually 2 cases with extensive intraductal component as well, and 9 out of the 12 had in situ disease, which highlights the difficult nature of these cases, which is also the reason that they were referred for the dynamic contrast enhanced studies. At our center, we only do them in cases when both ultrasound and X-ray or mammography provide ambiguous findings. So this was the main reason for all these patients being enrolled. They were not selected, especially for our study. These were just going through the standard procedure. Evaluating the breast volumes and also the breast tumor volumes and also the breast tumor diameters shows a significant difference between those 2 assessments in comparison to MRI. Specifically, this chart shows, for instance, on the left, the volume correlation along with the regression analysis and the 95% confidence intervals. And what you can appreciate here is the tighter fit and narrower confidence intervals for our volumetric study as compared to the diameter study on the right, where the values tended to vary from the standard, the established values quite a bit more. And this is also highlighted by our derived statistical assessment. For our dynamic contrast enhanced volume to photoacoustic volume correlation values, we got 0.78, which indicates a strong positive correlation. On the other hand, for diameters, we only got 0.54, which is still a pretty good correlation, but not as strong as for the volumes. And an even bigger difference using the Wilkinson signed rank test, which is used to establish the similarity or the comparison of the 2 data sets, where for our MRI volume to iPAS volume sets, we found a very strong, very high p value of 0.97, indicating that the two data sets are fairly equivalent. On the other hand, for the diameters, we found a significantly different, almost statistically different, just on the threshold of being established as a different data set. We found that with the iPAS scan of volumes, we only overestimated the volumes by 3.6% with a standard deviation of 15%. So a fairly large standard deviation still compared to the error. On the other hand, for the iPAS versus dynamic contrast tumor maximum diameters, we had a much larger overestimation of 28% with the standard deviation of 61%. So this indicates to us that the volumetric measurements are considerably more reliable and similar to what we expect to be the gold standard. So this study established a few significant limitations of our current system. Specifically, our system is unable to visualize surgical aids, which is a big standard for current surgical standard for intraoperative imaging, as we tend to use it to confirm the presence of radioactive localization seeds, as well as the position of other surgical aids such as tissue clips and guide wires. So currently the system is unable to offer that, but we believe that with looking into resolution so that we are able to detect these fine features by examining our transducer bandwidth would potentially overcome this difficulty. Also, in considering the preparation of the specimen during the intraoperative scan, a considerable amount of compression is applied to the lumpectomy. And this compression likely, because these are fresh samples, they're quite malleable. We believe that there's a considerable amount of deformation, compressive deformation applied to these tumors. And that then complicates our comparison to both preoperative MRI as well as pathology. And this is quite indicated in the fact that our diameters are significantly overestimated, while our volumes are not. So you can imagine, as you compress the tumor, you're going to get larger diameters, but the volume will tend to stay the same. Another issue was that the current standard of care does not involve documenting DCIS diameters. We only, our surgical pathology report, our pathology report only comments on the diameters of the actual invasive component. The DCIS component is not commented. However, we have evidence from our system that our system is in fact sensitive to DCIS components, but may not necessarily be able to distinguish them from invasive components. And as a result, when we are calculating both our volumes and our diameters, there may be a significant amount of DCIS that is being added in with our data set, whereas when we're looking at the pathology report, they do not include that in the diameters study. They simply state whether there is DCIS and how far from the margin it is. Finally, another issue, more of a technical comment, is that our laser has tended to have some instability in the laser output, in the power output, and so this was a bit of a inconvenience at times, causing a low signal-to-noise ratio. And as a result, some of the images in our study, about 10% of the images or so, came out with lower image quality than what we would hope. So looking into getting a really good stable laser system or an alternative illumination source would be an important next step. And finally, the lumpectomy holder is a cumbersome device that, while effective at holding the lumpectomy where it needs to be and allowing the photoacoustic process to be free of artifacts from the surrounding holder components, it does have some impediments to its clinical adoption in terms of ease of operation. So in summary, I'd like to say that we showed that our system has excellent bulk tissue sensitivity, and that this capability allows us to be able to visualize entire tumor masses based on their lipid profile. And we believe this is the first time that this has been done, where we were actually able to visualize entire masses based on their lipid profile, and therefore be able to carry out a study where we compare the volumes of tumors with a clinical standard like dynamic contrast enhanced MRI. And we found that indeed the performance of iPAS was quite similar with lipid-weighted imaging to dynamic contrast enhanced MRI. But we did find that it did significantly overestimate diameters as compared to pathology. And again, there's a number of avenues that we believe are potentially the cause of this, that we're looking into remedying for our next series of investigations. So in the future, to combat these issues, we plan on increasing the system resolution by augmenting our array with some higher frequency transducers. And we plan on approaching a pathologist that we can collaborate with in order to obtain detailed 3D measurements of both the invasive as well as the ductal carcinoma in situ components of these tumors. And once we have these capabilities, we would be able to repeat the study with the hope of being able to demonstrate an even closer or more similar performance to what is currently clinically employed. So with that, I thank you for your attention, and I'll take any questions.
Thank you very much, Dr. Ivan, for the wonderful presentation. So now the session is open for questions. Anyone have questions for Dr. Ivan? You can raise your hand, or else you can give your questions in the chat box. Any questions for Dr. Ivan? Yes, there is a question from Priyanka Sharma. So you can unmute your audio, you can ask directly.
Okay. Hi, Ivan. Very nice talk. Very nice tool. I was wondering, I think I missed during your talk, that if you calculate the efficiency in terms of sensitivity, then how much better your iPS tool in comparison to the classical scanning method in the clinics?
I'm sorry, could you repeat in comparison to if I establish my sensitivity?
If you have to talk about the sensitivity, means the sensitivity measurement by iPS, how much better it is in comparison to the classical way of scanning the tumor? Because
So okay, so when you say sensitivity, do you mean and it's in detecting positives versus negative, false positive, false negative, that type of thing, or do you mean sensitivity? Oh, okay. So what we found in terms of sensitivity is actually that the sensitivity was 81% and the specificity was 83%. So this was with respect to the sensitivity to what the pathologist measured as the margin status. So what we did was we did a separate study, and we're actually going to be publishing a paper on this soon, where we looked at not just volumes, but what we looked at was what the ultimate pathology report was saying in terms of the status of the margin and what we can do to prevent that margin from being overlooked during the surgical procedure. In other words, what are the optimum parameters? So we optimize our parameters for being able to detect specimens and be able to tell the surgeon, look, it is very likely that this margin is involved. It is probably going to be a good idea at this point to take an extra shaving, and it might be a couple of extra millimeters. It will not make a huge difference overall cosmetically, but it could really save the patient an extra surgery. And so with this approach, where we compared what the pathologist highlighted as the involved margins, and we compared to what we highlighted as involved margins, we came up with an 81% sensitivity and an 83% specificity.
I see. Okay. Thank you so much. Very nice. Thank you.
No problem.